Okay, so hi everyone, and welcome back to one of our live sessions. Today is a very interesting day. It's a very fun day because I have with me one of my friends, Dr. Fabrizio Horta. He is a medical reproductive scientist who started his career as a research andrologist 11 years ago. He is from Chile, and now he is in Australia. And he completed his PhD at Monash University, which was this year, Fab, right? And
Yes.
yeah, he has a great interest in andrology. He's published several papers and many chapters related to male infertility, presented them in various conferences. I heard him in Eshrei 2 years ago, and that's where we met. And then we had like a alumni session with Monash because he's also from Monash. So we had an alumni meet in Preto, and that's when we became friends. And it's such an honor to have you with us, Fab, today. And we have a wonderful topic here for discussion, which is sperm DNA fragmentation. So for all the viewers who are joining, just a few rules. If you have any questions for Fab, please type those questions into the comment section and we'll be happy to take them as the presentation goes. We're going to start with the initial discussion, so you can put in your questions in the meantime. And as soon as that initial discussion is over, we'll take all of your questions up. So that's pretty much it. You ready, Fab?
Yes, definitely.
Awesome. So, so again, welcome to all of you. Let's start with a brief introduction of sperm DNA fragmentation. So, Fab, what do you think about how does sperm DNA fragmentation basically originate? I know you've done a lot of research on sperm DFI. How do you think that it really originates, and what are the consequences of sperm DNA fragmentation on reproduction?
Well, first of all, thank you very much, Ketchup, for inviting me and being here. It's also a really honor to be part of your webinar and presenting here about my research and information about sperm DNA damage. But now taking your question, well, we could say that the origin of sperm DNA damage mainly between an 80 to a 90% is going to be post-testicular. We know that the sperm DNA damage, it doesn't generate mainly from the testes. Once spermogenesis is finished, it is complete, and the sperm start then transport into the epididymis, and then they start their way out into the ejaculate, is where when we actually the problems start. That could be for several reasons. It could be mainly for instance, reactive oxygen species, problems that a man is facing due to the environment, maybe diet, um, drug consumption, alcohol, smoking, etc. All that is going to affect at that level. So, and then is when actually sperm DNA damage can happen. However, still it could have an origin in the testes, and that it could be due to factors or failure in the spermatogenesis itself. There are some evidence that during the spermatogenesis, the DNA repair, I mean, actually sperm cells cannot conduct DNA repair. Only spermatogonian cells can repair, but then if anything has happened and affected DNA in the sperm, they keep going. Normally, there are specific cells that are on charge of control the spermatogenesis, called Sertoli cells. They are in charge of trying to find out all these sperm cells that could be affected. But sometimes they fail. They fail to detect a sperm with damage, and they actually release. And that's one of the regions as well of the DNA damage. Other things that we know that affect at that level is, for instance, radiation, especially chemotherapy. It affects specifically in the testes, but it's not something that is that common. So mainly, if I'm trying to summarize the answer, mainly would be post-testicular, and it would be due to reactive oxygen species, the environment.
Yeah, we've kind of understood that the one of the main causes for sperm DNA damage is post-testicular, and that's because of the reactive oxygen species that are being produced inside the seminal plasma. and how it actually affects the DNA of the sperm. Now, can this be controlled? Is the next question, and what are the kind of indications that a man would, if a man is coming into your clinic, how would you suspect that he might be one of those potential cases where sperm DNA fragmentation might be high? So what would be the indication?
And you mean an indication to try to improve that
Just
condition?
just yeah.
Yeah, well, for instance, we know that there are some conditions that are clearly associated with increased reactive oxygen species. The most critical one is smoking. We know that smoking is actually leads that the balance in terms of the reactive oxygen species, that it could be uh, across all our body, it change. So there is start to be an unbalance, and that also happen in the seminal plasma. And then if we have a sperm that are more susceptible to DNA damage, they will that will facilitate that they get DNA damage. And the same is going to happen with some environmental conditions. For instance, if they are exposed to some certain toxins, pollution. Actually, pollution is just a very normal one. Some countries that have a higher pollution, maybe could be the case in some cities in India. But we know, for instance, that in some cities where with high pollution, like Hong Kong, um, the number of cases of males presenting infertility is actually higher, and
Yeah.
the levels of sperm DNA damage in those patients is quite common. So basically, the environment tells you a lot that could be a problem. And then how do you face that? How you can do normally, even though seminal analysis itself is a very good reproductive test to see the health of a male, sperm DNA damage seems that also is a good factor in that sense. And if there are several factors or conditions that are not healthy enough, like smoking, being exposed to toxins, pollution, increased BMI, poor diet, uh, that it could lead that they will have sperm DNA damage in their samples.
Yeah. So thank you for actually enumerating all of these conditions. We also know, and I think this is part of your research as well, that the age also contributes to the integrity of DNA inside the sperm. And I think it's a common misconception that because men can produce sperms for a longer time during their lifetimes, that they'll be able to conceive even later on. But I know that you've done your research, and it probably says that I think post 40, after every 1 year of like trying to conceive, after I'm sorry, post 40, after every 1 year of life, the chances of live birth go down by 4% or something. Is that true? Okay,
Yeah,
so can you enumerate on that, please?
yeah. Thank you very much for asking that one. Yeah, we have done at Monash as well research on male aging and reproductive outcomes. And yeah, in summary, we have found that um, every year a man get older, the chances to achieve live birth decrease around 4.1% which each year. We normally take as a cutoff value 40, just to because it's easier to understand, but it's important to recognize that there is no guidelines to indicate when a man is of advanced reproductive age.
Yeah.
But a man, basically, when we are getting older, even me and you, we are young, right? I mean, I consider young.
Yeah.
We actually, every year we get older, we are getting actually more likely we are reducing the capacities to achieve live birth. Uh, but that it could have an origin as well in sperm DNA damage. I didn't mention it before, but um, the age is one of the factors that actually has been strongly linked to sperm DNA damage. And of course, that is something that we cannot control, right? I
Yeah.
wish we can, maybe in the future we will have that, right? We will develop that some age reversal thing, and maybe we will be able to reverse age somehow. Not sure it's gonna be too good, but um, yeah, that is one of the factors, and mainly the way why how is this is happening is that our body, when we are getting older, uh, the mechanisms to for instance, have our balance of reactive oxygen species start to fail. So we are not able to reach that balance in a as simple as was when we were younger, and then our cells, if they are exposed to any type of bad conditions, such as reactive oxygen species, by smoking, by having high intakes of alcohol, by not having a healthy diet, then it's more likely that actually your sperm will get damaged. It's not when you were young that maybe you were too party and
Yeah,
and and then you will recover actually quite faster. But if you do
yeah.
that when you are older, probably it's not gonna be that great for your sperms, unfortunately.
So I'll ask you a frequently asked question, uh, which is basically, so can you see any effect of an increased sperm DNA fragmentation on like normal semen analysis parameters? Like, would these sperms have a poor motility, or would they be morphologically the same? Or can you actually try and figure it out by just doing a semen analysis, and then maybe do an advanced test? Is that possible?
That is a pretty good question, especially from the laboratory perspective. Uh, well, unfortunately, sperm DNA damage doesn't correlate well with any of the sperm parameters, even though there are some parameters that are closer. For instance, motility. When we have a lower motility, so sperm that actually are not swimming properly, uh, is more. There is a higher chance that you could have, but it's not guaranteed. Uh,
Yeah,
Something that is really, I would say, 100% uh, quite likely is when we have really high levels of dead sperm. So, for instance, samples that are really not with a lot of sperm that are not viable, then is really likely that the sperm is having a strong issue. But those samples, especially you work in the field, are not that common. We don't have that as many guys that have really a lot of sperm that are not viable. But when that happens, it's quite likely that there is a DNA damage there. So a clear example is going to be necrospermia. So samples that have a high number of sperm dead, then yeah, there is a high chance. But normally, unfortunately, it's not predictable, and you can have samples. Guys could be totally normal, and they could have high values of sperm DNA damage, and we have seen that in the practice. It's not that common, I would say,
yeah.
but it can happen.
So again, this is a very important point for all the audience who are listening. Even with normal semen analysis parameters, it is a possibility that the DNA fragmentation of that sample might be high. And that is where you would want to segregate your patients based on the kind of indications that they present with. So something like maybe recurrent miscarriages, something like advanced paternal age, or advanced age of the man, or if you even have like abnormal embryonic parameters, like if the embryos are arresting at let's say the 8 cell stage, or the blastulation rate is a little low as compared to the others. These are probably indications where you can offer an advanced test in the form of sperm DNA fragmentation. Fab, any other embryological outcomes that we really need to look for, especially when we're talking about the paternal contribution? Would
Uh,
you?
yeah, that's a good question. Normally, fertilization is not too related. I would
Yeah,
say sometimes people think that fertilization could be affected, but it's not that true. Uh, Something that you as an embryologist you could take into account is utilization rates. So basically, the number of embryos that you either transfer to women or you actually vitrify. If
Yeah.
also they go down, that is another good sign, because basically the number of blastocysts that you produce in your laboratory, it could be affected due to a paternal origin.
Yeah.
Also, late has been linked that the first cleavage also it could be a sign of paternal origin. So if there are delayed in the first divisions of embryos, it could have a paternal origin, but it's not that clear. But there is some good studies out there. Uh, but it's what you mentioned. I really like it. It's a good point, because I will say something that we should do better for management of sperm DNA damage is that why we have to see those elements that involve treatment already, and why we cannot detect them earlier. Like I wonder, and
Yeah.
we have questions with students as well, like why we have to wait 3 times that a couple failed treatment to actually test them.
Yeah.
Why we don't do it actually straight at the beginning, right?
And
Uh,
I think that's where the evidence comes into play, because we were just talking about data and all the evidence to support all of these add-ons, and I think it's still not clear whether, like, doing a sperm DNA fragmentation test right at the beginning of the cycle before the patient has had any other diagnostic test being put on them would benefit them clearly. So that's probably it, and we need more trials to actually ensure this. But we know that the DNA of the sperm is a very crucial factor, and
yeah, so
that's something that we have to consider.
exactly. So following that one, yeah, I would like to add that I'm not telling that from my side, I'm not recommending routine use.
Yeah.
Uh, I'm not recommending testing in the routine straight away, but we have to study. We have to answer
Yes,
the question first. Like,
that's true.
should we include it in the routines testing or not? But to do that, you have to first start with some studies trying to answer that question. And but definitely, if we have some cases where we have recurrent implantation failure, or treatment failure, or recurrent miscarriage, and we know that has been linked to this, why we are expecting to wait, or this actually treatment failure happen to actually do the test. So we are trying to address that. I don't know, maybe we have a student maybe here present, but there is a student that is will try to answer that
Yeah.
question.
Yeah. So we discussed a little bit about male age. Now let's move on to the female age and how it affects uh, the repair capacity. Now again, you've done your research here, and I saw the link that you shared with me. And for all the viewers out here, Fab was in the news in Australia for his research on female age and how it correlates with the sperm DNA repair capacity. And you basically mentioned there that if an older woman has a better chance of having a live birth with a younger man as compared to an older man. That those are your words, right? So would you like to elaborate on that?
Yeah, that's a good one. Yeah, well, looks like, yeah, we are changing the paradigm, right?
Yes.
uh, well, um, basically, it's something that we know theoretically, that the eggs of women, the oocytes, they have the capacity to repair DNA, and has been hypothesized in the past, all these years, that that capacity decreases with age. So if you consider that, and we know that actually it's possible that the oocytes can repair damage from the sperm, uh, women as they get older, if they have a reduced capacity to repair any type of damage, and older men actually have an increased chance of have sperm with DNA damage, yeah, that is going to be really the worst scenario. So when we have couples of both being older, but when you have, for instance, a woman of maybe advanced reproductive age, it would be really critical. Potentially, is something that we still have to answer really properly. Potentially, that in that scenario is when you have to really be sure that the sperm are good,
Yeah.
because at that advanced reproductive age, the capacity to repair DNA damage from the sperm or from the oocyte itself, themselves, is going to be reduced potentially. We have we published a study in human reproduction recently in February, and yeah, we found very significant data that is telling us that the oocytes from females of advanced reproductive age, they have a reduced capacity to repair double strand breaks. So if there is damage that is important of double strand breaks, it's going to be really hard to handle for the oocytes. And this could be even damage from the female side as well. We
Yeah.
hypothesize as well that the oocytes probably are carrying damage as well. We haven't demonstrated that clearly yet, but we hypothesize it. And also, maybe what I would say the most important or a special finding is that it's not just a decreased capacity to repair double strand breaks, also a reduced capacity to respond to DNA damage, even if the damage is there. And that is, I would say, the most important finding. And but it's very very novel. So we have to do way more research to actually demonstrate it. And there is also one student at Monash University that her research is focused in trying to demonstrate in different pathways that actually the oocytes uh, are. She's trying to find if actually we are right, if they are responding less with age.
Yeah. So you touched upon double strand breaks and single strand breaks. Now, again, would you like to elaborate on the kind of um, like outcomes when you have a double stranded break or a single strand break? Obviously, we understand that if it's a double stranded DNA break or DNA fragmentation, the outcomes are going to be poorer. Is there any way of figuring that out or testing whether it's a single stranded break or a double stranded break? And again, when we're talking about testing, what are the different kinds of tests that we are using for sperm DNA fragmentation?
Yeah, that's a good one as well. Well, some to start with that question, it's important to recognize as well that the oocytes and all cells, all the cells of our body, well, except by the sperm, unfortunately, uh, they are able to conduct DNA repair of either single or double strand breaks.
Yeah,
So there is mechanisms to actually conduct this type of repair. Normally, in our daily life, we'll have more single strand breaks, and that actually normally happen. And in fact, even double strand breaks could be physiological when the cells go through mitosis, and in the case of reproductive cells, they go through meiosis. There are double strand breaks that are actually physiological, and the cells is able to detect them and repair them in a normal way. But in the case of a sperm, there are tests that we can detect the type of damage. If it's single and double strand break, and there is one test that is called Comet SI, and it's the
yeah,
only one that is actually able to do that. Normally, the tests that we use in clinics, such as I would say maybe the most popular these days is becoming the halosperm.
yeah,
Uh, it's a mixture between single and double strand breaks. Uh, and in the case of the, well, it's another test called SCSS, the sperm chromatin, sperm chromatin,
SCSA.
yeah, SCSA test. The other one is mainly single strand breaks. We cannot tell that which one will be the best one. Of course, there is some evidence that is telling that maybe tunnel. There is another test that is more direct. Actually,
Yeah,
have a really good level of evidence, um, but Comet SI is the only test that actually it could provide you information and from single and double strand breaks. And if a guy has actually an increasing number of double strand breaks, it's quite likely that prognostic factor is poor. And there is
Yeah.
some new data coming from UK that actually, if you measure only double strand breaks with Comet SI, the prognostic factor actually is way much better, even for live birth rates for
Okay.
ICSI.
Okay. So what you're trying to say is that obviously there are so many tests which are available, like you have Comet, you have Tunnel, you have SCSA, and obviously the Halosperm, which is most commonly used. Do you have any experience, or would you like to share your experience, clinical experience, on what kind of tests do Australian clinics use, or and even in Chile, what kind of tests are being used in your setups where you were working?
Yeah,
Was it Halosperm?
well, Mike's in clinical experience, I have the chance of working with Halosperm, with Tunnel, and with SCSA.
Yeah.
For research purpose, I've worked with Comet SI. Uh, the Halosperm is definitely very easy to introduce, and I think that is the reason why it's gaining popularity among the clinics, because it's pretty simple. You know, there are kits out there, commercially viable. You don't need any different complex equipment. You can use exactly the equipment that any lab could have available. So
Yeah.
it's pretty easy. When you compare this test with the other ones, normally they are pretty comparable. They correlate well. So there is no really, I wouldn't say nothing extremely as evident to actually say, well, no, don't use that one.
Yeah.
Um, I think we need more. We really need just more studies in terms of live birth. I think that is the issue with sperm DNA damage. That the majority of the studies only focus clinical pregnancy or miscarriage rates, the maximum, but we don't have enough data in terms of live births.
Yeah.
So I think if we make more effort in trying to have longer studies, then we will be able to find out better prediction possibilities from this test. Um,
Yeah, and that's where I think this question from the audience is also coming into picture, because a lot of us do get confused about which test to recommend to the patient. Now, if you're working in a clinical setup, you obviously have Halosperm, which is easily available to you, or SCD. I'll not even name the brand of it. So SCD, or sperm chromatin dispersion, is easily available. It can be done in most of the laboratories. Doesn't require much skill and training, and the results are comparable to SCSA. So that's something that can be easily implemented for your patients, and that's something that you can offer to them at a relatively economical price, and that's something that should be taken into consideration.
yes, definitely.
Yeah.
I would say the only problem with Comet, although I don't have clinical experience, only I've used it for research purpose, is complex. It's very complicated to implement.
Yeah.
Although there are some specialized labs these days that you can send samples over, like there is a laboratory in UK from China.
Yeah.
Uh, she has done plenty of research in Comet SI, and yeah, you can send the samples over here.
Yeah. Okay, so we've discussed a little bit about the tests that are available. Let's start talking about the cutoffs for sperm DNA fragmentation. Now, what would you consider as normal? And like then we'll start talking about the interventions that can be offered for the abnormal sperm DNA fragmentation ranges.
So sorry,
So what would be your
couldn't get that
so
question.
what would be the cutoff? What would be the cutoff as far as normal sperm DNA fragmentation is concerned? Like what percentage would you consider as normal?
Okay, that's a good one. That it will depend of the test, and normally every test has suggest some cutoff values. Normally, halosperm relates pretty well with SCSSA. So normally for that one is around 30%. So any
Yeah.
guy over 30% is will consider with high sperm DNA damage. But for Tano, that is a direct test, the cutoff values tends to be lower, normally between 12 to 20%, depending on the study. And for Comet S-side also are around that line. So in that case, you should have a look in terms of the test that you are using and you are referring to. However, something very important that I think we have to recognize, and we are doing research on that as well, is that all these tests, or all these studies so far, they haven't incorporate or take into account the female age. And as I mentioned you before, based in our research, based on our studies, um, it's quite likely that the impact of a sperm DNA damage is higher in women of advanced reproductive age. So maybe women over 37, the cutoff value for men is going to be actually lower. So
Yeah.
if you consider a guy, it's a higher chance that a guy it will have an impact earlier in women of advanced reproductive age. So, but yeah, we need some time, and we'll have the papers sometime. So give us just some time. I will be
Yeah.
able to better that one.
And that's a very good point put by you, Fab. That and that's something that most of us don't consider. Like we can't have a fixed cutoff, especially when age is such an important factor, and the repair capacity, especially from the female side, is an important factor. And we already know with the kind of research that's coming up that an advanced woman who has advanced maternal age, even like let's say more than 37, would have a lower capacity to repair. So you would not be able to use the same kind of cutoffs for which you offer for your normal patients. Thank you for that very interesting point. Now, what do you really do when you have like a very high DNA fragmentation index? So
Oh,
what are the
patient.
kind of interventions that can be offered?
Okay. Well, that is when this uh, start to get complicated, and this could lead to a discussion, a matter of discussion.
Yes.
Well, I think that is the biggest problem, as we'll say, for sperm DNA damage, and this is the issue clinicians are facing, because we don't have really good evidence to know what to do, and that's heredity.
Yeah.
Like, what do we do? Like what, how strong we can be to actually said, look, we can take this direction. And unfortunately, at this stage, we don't have, definitely there is very low evidence that use of antioxidants or antibiotics, it could be a solution, although
Yeah.
those treatments are prescribed. And there are still clinical trials ongoing. People is doing clinical trials at this. That is good, but it's are really hard to control. And also, then the other question is, for how long you will treat a male
Yeah.
to actually
Yeah.
produce changes. Uh, Changes on diet or changes in these conditions should be minimum 3 months. So it's going to be long treatments, 3 to 6 months. In clinical experience, uh, uh, with the urologists we work, we normally the treatments were 3 to 6 months antioxidants if the patients were willing to actually go ahead, even though we have very low data, very low evidence, so very low
Yeah.
evidence. As the ones that are willing to go ahead and try it, you can see differences. You can see differences. You actually observe that DNA damage in some of them goes down, um, but in some of them that never happen. So then, what is other possibilities? Other possibilities is, I would say, what sounds from. I will start from the easiest, is frequent ejaculation. Uh, we know that cleaning the pipes in the guys, if the guys clean the pipes, is actually way they reduce the levels of sperm DNA damage. We know that, as I mentioned at the beginning, the majority of the damage is post testicular level. So that happen in the transport from the start of the epididymis until we find the sperm in the ejaculates. So if the as we as human as a species compared to other mammalians, we don't have a sperm storage, but so we are constantly we can release. But if the sperm actually are not used, when they reach the tail of the epididymis, they normally just macrophages come and eat them,
Yeah.
and you eat, and this is the reason of the detritus. That's why you see in when you analyze sperm samples, you see a lot of little detritus. It's because the sperm are constantly dying as well, and all the cells come to actually eat them and discard them. But if you are constantly ejaculating, the sperm will be released, will pass through the epididymis, and the straight go out. And that would be a good practice. Although, of course, we don't have clinical evidence to demonstrate that guys with higher frequent ejaculation actually produce better IVF outcomes. There is evidence that actually you are able to reduce the levels of sperm DNA damage. Another one that there is good evidence is the use of testicular sperms. But this one, oh my God, this is a tricky one for me to talk about because I mean, this started earlier. Like this, the first data came in the 90s, and and
Yes.
and and they show that actually sperm from the testes present lower values of sperm DNA damage compared to ejaculates, and that's there. And there is a lot of papers showing that is a fact that is real. However, in terms of randomized control trials, which is the actual truly evidence that we should use to prove a treatment in our patients, we don't have. We don't have, unfortunately. So
Yeah.
I know makes a lot of sense to put our patients that the ones that have a high DNA damage levels. It makes a lot of sense if there is nothing work, nothing actually make them to reduce their levels. Uh, Maybe try that as an alternative. However, we have to understand as well that even we don't have proper randomized control trials to actually say that by reducing sperm DNA damage, we are improving IVF. So I
Yeah.
think it's important. It's an option to consider. Definitely, I know that in India it happened quite often. In my case in Chile when I worked there, we did it as well a few times, not too many times. We try it in some cases, uh, and but I wouldn't say. I mean, we need more evidence. I think makes a lot of sense. I'm sure that you will find a sperm with lower DNA damage. That's there's a
Yeah.
lot of evidence for that.
But it's the invasiveness of the procedure,
It's
and
the
is the kind of pain that the man is being exposed to, and the kind of long-term effects which we don't even think about, like fibrosis of the testes. Because if it's not done in good hands, a testicular biopsy or a testicular aspiration can induce damage in the testes. So these are certain things that we have to consider. And again, I completely
exactly
correlate
like
with you
how
on
to
these
balance.
points.
Yeah, how to balance. Like it still is an intervention, right? So we're putting a
Yes.
guy in surgery. I know it's not that complicated. It's painful, but not that much. Still, they
Yeah.
go maybe the same day they go home. But um, is yeah, I would say we should do randomized control trials where we have a control group that we don't do treatment at
Yeah.
all. We put
Yeah.
them. We try as well guys were high values, and we put them through testicular sperm sample, and also a third arm where we use another sperm selection method. That maybe if you want, we can talk about sperm selection methods. That I think
Yeah.
that's another big option as well as treatment.
Yeah.
Treatment
We'll
in
come to that. So we'll come to sperm selection after this question. So the audience is asking, which antioxidant would you prefer if DFI is high? I know there's a complete lack of evidence on the kind of antioxidants that are present, but it's very common practice by most clinicians that they would prescribe a combination of antioxidants, and most of them prescribe antioxidants even when there is no indication, just so that it kind of improves the quality of semen. So do you believe in that practice? And then, and the second question would be, what are your preferences with antioxidants? Have you seen any like specific compound behaving better or not?
Yeah, no, and that one I would say I don't have any position about it because the evidence is very low. Unfortunately, we there are so many things out there. You can actually put so many compounds, different compounds. Uh, there are some that maybe could be better, but actually I wouldn't take it into a position because the evidence is so low that if I make a recommendation, I think is not
Yeah,
too responsible. Uh,
yeah,
but I think we have possibilities, especially maybe in India as well, that to do interventions on diet, like research on diets as well. Maybe it could
yeah.
be more controllable. Maybe you can make better control of it. But yeah, with antioxidants, unfortunately, is really complicated to actually make okay, this is better. No, unfortunately, not with that one.
Yeah. So the next question, which is coming up, and that's something that we should be discussing. Now, once we know that the DFI is a little high, would you end up with IVF, or would you choose ICSI, or would you choose any of the add-ons which are there, like Pixie, like microfluidics, like Max, or testicular sperm? So what would that be? What would your position on that be?
Okay, say if we recommend IVF
Let's
or
let's start with IVF and ICSI. What would be better for such patients?
okay, uh, well, it has been normally proposed that ICSI is could be an option, a possibility for guys with higher sperm DNA damage. If you don't have any intervention, yeah, that would be an option. Why? Because mainly the IVF itself, even though is we know that is even though we do it in the lab, uh, is still artificial insemination. But we the interaction between eggs and the sperm, it leads that the cumulus cells start dying, and that involve releasing of reactive oxygen species, especially when the sperm they react with the eggs, they release their content from the acrosome, and that also involve reactive oxygen species as well. So that environment, having them in culture with the eggs, maybe will make them more susceptible to actually get damage or reduce possibilities. So then in the ICSI, you avoid that. So that culture, that incubation, also we know uh, that sperm, especially guys that have present higher values of sperm DNA damage, if you culture the samples at 37 degrees, actually the levels go up.
Yeah,
The levels go
yeah,
up. So if you can avoid culture of the sperm samples, that actually is good in the lab, like as a normal practice. Even
yes,
could be recommendable to any sperm preparation to actually have it a normal a room temperature, because by having normal conditions, uh, it's more likely that actually sperm DNA damage start happening, and in guys with higher values that the sperm are more susceptible. Uh, there is some evidence that shows that this could happen even uh, just after 30 minutes. They start producing more sperm DNA damage, especially as
yeah,
cryopreserved samples.
yeah. So we obviously know that ICSI might be a better choice here, because especially if you're doing conventional IVF and you're leaving the sperms inside that same well for, let's say, 16 hours, that's something that's going to increase the ROS, because sperms are going to continue to die. There's cumulus which is present inside. All of this is going to produce ROS, which will hamper the quality of the sperm as well as the egg quality as well. So So that's something that should be thought about. But what about sperm selection? Now we know that ICSI is an option. What are the other things that can be done as far as selecting the best kind of sperm is concerned?
Well, that is something good. It's a good question. I think it's something that we should determine with time. Uh, and actually, we saw some good research coming from India and ASHRE this
Yes,
week. We saw
yes,
Krishna,
we did.
and that's great seeing colleagues as well, Monash alumni
Yes,
from India presenting in ASHRE. Yeah, we need to do more research like that actually to identify what are the better sperm selection techniques. Uh, the evidence out there, well, look, it's complicated. We cannot really tell exactly which one is the best till now. Uh, I think uh, I think there is more evidence for Pixie, I would say, because last
yeah,
year it was presented. Last year was published one really big study done in UK that was published in the Lancet, which is a very high impact journal, and the results in favor of Pixie are quite surprising, even though it didn't reach statistical significance for Pixie in live birth. It was very close, and so it's
yeah,
something about sample size probably, and also the studies as well are not focused are not focused in the type of guy having the issue. So they were trying the technique across all type of patients. So something that I really like from the study of Krishna, I will say, and actually we should do more and take that as an example, is the fact that we study a specific population. So studying the guys that are actually presenting high values of DNA damage is the way to go. So we have to study
yeah,
those guys. We have to see what is the best treatment for them, specifically for them, because not all the people will necessarily have these interventions are good. I mean, and I think that is the big point here. Probably a sperm selection is it could lead to improvements, but only for some type of patient. And the ones that will have a benefit probably are the ones that have a high sperm DNA damage values.
yeah,
So in that sense, I think it's good to see that the study as well from Krishna, and I think what I would advise is to always try do a randomized control trials where you compare a control group, so no intervention at all, versus the treatment you want to compare. And if you want to compare two treatments, will be ideally do a 3-arm study. I know it's going to be more complicated and will take more time,
yeah,
but yeah, that's Max. Definitely, I know Max is quite common in India. I do have experience with Max as well. The only issue with Max, I would say, is that oligospermic patients are hard to actually risk the sample, right? So
yeah.
is the management of those patients is a bit complicated. Even doing tests with them is a bit complicated.
Yeah,
Uh,
so that's the next question, which is already here. If the sperm count is very low, it's going to be difficult to estimate DNA fragmentation and even like select the best kind of sperm in that particular scenario. So you actually answered that right there, but we can elaborate a bit upon this as well.
Yeah, so in that sense, then Pixie actually is good because
Yeah,
it works pretty much like an ICSI dish. Or there is another version, the sperm slow,
yeah,
uh, that you see the sperm that actually are moving slower in terms of motility. Actually, are the ones that are having the receptors working with the hyaluronic
yeah,
acid. So yeah, I think, and also Pixie makes a lot of sense. Originally, I wasn't believed too much in Pixie, but recently, even coming from Australia, research coming from Australia have demonstrated that when sperm cells are presenting sperm DNA damage, or they have been damaged through reactive oxygen species, the membranes, the protein that are present in the membranes, they start to change. Actually, cellular membranes are pretty flexible, and they can change their conformation.
Yeah.
And it has been demonstrated that mature sperm, when they are damaged, the protein expression in the membranes actually change as well. So uh, yeah, and that has been linked to the sperm DNA damage as well. So I think we are having more and more strong evidence as well that a lack of interaction with the egg, it could be affected as well in that sense.
Yeah. So let's move on to some of the factors in the laboratory that could affect sperm DNA fragmentation. Now, is there a role of does cryopreservation induce damage? Because again, there are studies which say that cryopreservation can induce damage, but then if you look at the some of the tests which are done, especially like Tunnel and Comet, where you might need to freeze the sample and send it for analysis. So what would your views be on this particular scenario?
Yeah, well, sperm cryopreservation definitely produce DNA damage.
Yeah,
That is a fact. So we have to understand, although we have to comment that even though we know that sperm cryopreservation produce DNA damage, in terms of evidence, the largest study comparing fresh sperm versus cryopreserved sperm doesn't show differences in terms of live birth for IVF and ICSI outcomes. So it still looks like cryopreservation is a safe procedure to have, even for testicular sperm as well. Even now in ESHRE, this week it was presented as well a very large study to compare the use of fresh testicular sperm compared to cryopreserved testicular sperm, and they were not show any difference in terms of live birth outcomes. So it's a safe method. However, is something to consider anyway, because we know that it still produces DNA damage, and I think what it matters is how we handle the sample. We know that the samples that has been that have been cryopreserved, they tend to show higher rates of DNA damage faster. So there are some evidence from Spain that the samples that you thaw that you are thawing, just after 30 minutes after you thaw them, they could start to show higher values of sperm DNA damage. So then the recommendation with cryopreserved samples will be that once you thaw them, use them straight away, and then it should be
yeah,
fine. So if you leave them for too long sitting in your bench waiting, that wouldn't be that good, especially for those samples. Now,
yeah.
following the same, it applies very similar to sperm
To
preparations.
ejaculates. Yeah.
Yeah.
Any
So
criteria or not criteria? What choice of sperm preparation would you advise? Like, because we know now there are some studies which say that density gradient could inflict DNA damage. There are some which say that density gradient is actually better for sperm people with high sperm DFI. What would be your take on this?
uh, good, good one as well, because some clinicians always have their preference, right?
Yeah,
And but based on evidence, the actually we haven't. There is no review of that one. Actually, we should review that
yeah,
one. But the last the last review, Cochrane review on this shows that there is no differences for use of either swim up or gradients.
yeah,
Yeah, actually, I would tell this to the student that we are finding we're trying to review something again. So yeah, well, maybe should review this. But yeah,
that's great.
but yeah, swim up and gradients. Actually, doesn't show any clinical differences, so you can use
Yeah.
either. What I would say matters is that we know that if we focus on sperm DNA damage again, uh, we know that infertile guys that present some level of sperm DNA damage, there is variation in terms of how the levels increase in the sperm preparation. So there is some
Yeah.
guys that maybe even after an hour of having the sperm sample ready for ICSI, for instance, you made your preparation early in the morning and you're doing your ICSI around, I don't know, 1 or 2 p.m. Maybe that you don't know, and that guy actually is producing higher levels of sperm DNA damage. And
Yeah.
we don't have a really good way to predict it, but we know that there are differences among men. Uh, is and one of the reasons it could explain this is that the susceptibility to the sperm DNA damage also lies on how compacted is the DNA, and the DNA in the sperm is compacted by some group of proteins that's called protamines, and
Protamines.
the protamines also change, are different in every guy, the level of how many they have. And so how compacted is the DNA also can vary, and also even has been suggested as well as a marker of infertility. Uh,
Yeah.
we know that when guys have a variation or lower expression of protamine, so then the DNA is not that compacted, then the sperm are always more susceptible all the way through. Uh, and they could have they could present higher values of sperm DNA damage faster than other guys. And just by having the sperm ready 1 hour, it could be damaging for them. So then we induce damage in the lab. As a normal rule, I would say, if you prepare your samples, always gonna be better use them as soon as you can. Of course, we know that in terms of how we work in the IVF lab, that is not something too easy to do.
Yeah.
But ideally no more than 3 hours, and keep them at room temperature.
Yeah. So that's a very, very important tip. I think this is something that we also try to follow in most of our cases. But like when you're doing a lot of cases on the same day, in those scenarios, this might be a little difficult. And that's where like timing your patients and scheduling the collection of the samples is something that you should be looking at in order to get the best kind of outcomes. So we're going to take the last few questions here. So if you have any more questions, please type them in. We have another one here. So apart from Pixie, is there any other intervention that is showing some kind of like clinical significance? We know Max has a potential, but what about microfluidics? Could you enumerate a little bit about IMSI as well? Uh, do they actually help out in these cases?
Okay, good. Well, IMSI, I don't know why a lot of people, when the IMSI came out, they love it. It was like,
Yeah,
oh, let's have a look the sperm very very close. and uh, and yeah, I mean, amazing to have technology, right? We, I
yeah,
think, in this field we love technology, but it hasn't shown any really improvement, and also um, uh, has been linked that the presence of vacuoles is actually something to avoid, and that you can see
yeah,
with IMSI. But at the
yeah,
same time, there has been demonstrated. I mean, we don't know really what is a vacuole, to be honest, and the vacuoles actually are dynamic. They change. The sperm, you can see vacuoles if you see them closer, but these vacuoles are moving. Uh, so IMSI, yeah, hasn't shown the really good outcomes, and also it takes a lot of time. It's really
yeah,
time demanding, and also there are, if as it's really linked to morphology, we have to just recognize that there is samples that don't have good morphology. I mean, they have zero sperm with zero morphology. About
yeah,
microfluidics, I would say I wish they could produce good outcomes. We have to understand that even by doing a gradient or a swim up, we are reducing the levels of sperm DNA damage. So I'm not surprised that microfluidics do the same. Uh, However, we don't have up to date a single sperm preparation technique that actually is able to identify a sperm by their DNA integrity.
Yeah,
So I think there is possibilities that microfluidics it could reduce as well, but there is not gonna be any fundamental biological reason behind to actually be able to then take an sperm in ICSI and actually inject it, being sure that that sperm doesn't is not carrying DNA damage. So
that's true.
for everyone out
That's
there, the message is that we have to recognize that all the sperm preparation samples or techniques that we are developing, we are reducing a population with damage, but always the sperm with damage could be out there. um, we have to develop a technique that is actually is able to detect the single sperm, the gold sperm that
yeah.
actually doesn't have the DNA damage, and we've been working on that as well. It's hard though. We're still not there, but but it's something that we have on mind.
Yeah, and that pretty much sums it up. There is no real time test. Maybe Pixie is something which is close to it, but it's still not 100% specific. And even with all of these add-ons that we use, we might still be injecting a sperm with a compromised DNA or with other things that can be compromised, like the PLC zeta, etc., etc. There's so many things that can go wrong. Could still be injected, and we cannot be 100% certain. So I think that should be the end of this discussion. So thank you so much, Fab. We'll just sum it up now. So sperm DNA damage basically is an important factor to consider as far as outcomes are concerned. The cutoffs that we discussed are, let's say, to the tune of 30%. That's the cutoff that we're trying to take, and that's above that we would want to initiate some sort of intervention. Now, the best kind of intervention here is lifestyle modification, because that's probably one of the most common causes of sperm DNA fragmentation. We know that antioxidants, logically they should be working, but there is no evidence to support the use of antioxidants at the moment. So there's no RCTs which have been done, or robust RCTs which are showing clinical significance. There are a lot of sperm selection modalities which are existing in the market, but just to like briefly sum it up, it's probably ICSI is better than IVF in these scenarios. And when you add on, maybe Pixie has the best kind of evidence at the moment. That also is not robust, but apart when you consider the others like microfluidics, Max, IMSI, etc., Pixie is probably leading that field. And let's talk about, we also talked about age. So male age affects sperm DNA fragmentation. So men who are above 40 have a higher probability of having sperm DNA damage. And like Fab mentioned, he's done his research in this field. With every 1 year above that, the live birth rate goes down by 4%. So that's the kind of influence that age could have on sperm DNA fragmentation. Female age also has a major role as far as the repair capacity is concerned. So younger eggs, or eggs from younger women, have a better capacity, and as the a woman's age advances, the capability of repair decreases. So maybe if the partner is younger, these women might have a better chance of conceiving naturally and having a live birth. So these were all the things that were discussed. So thank you so much, Fab, for that wonderful discussion. And lots of research ideas have also emerged from this conversation. And hopefully, if there are any students who are listening, you can get in touch with Fab. And I'm also going to get in touch with you and maybe discuss further collaborations. Right. So thank you so much for joining us. And thank you to everyone who attended and asked questions. Have a good day.
Well, thank you very much, Kechav, for everything, and also to all the friends in India. Thank you very much for being here. And if you would like to chat about, feel free to contact me as well. And happy to help you as well doing research. Happy to do collaboration as well.
Yeah, awesome. Thank you so much, Fab, and bye bye. Say hi to everyone back in Australia.
Thank you. Take care.